Can we start now?
Good evening, all. On behalf of ICMR National Institute of Research in Tribal Health, greetings and a warm welcome to all of you on this special occasion. We are thrilled to have you joining us. We are thrilled to have you joining us for today's webinar on rare genetic disorders. ICMR National Institute of Research in Tribal Health, greetings. We are thrilled to have you joining us. It's worth noting that today's date holds special significance. February 29th is celebrated globally as Rare Disease Day. This observance serves as a poignant reminder of the unique challenges faced by individuals and families affected by rare diseases. As we come together on this day, let us renew our commitment to raising awareness, fostering collaboration, and advocating for those whose lives are impacted by rare genetic disorders. Our expert speakers will shed light on the latest developments, research, and challenges surrounding rare genetic diseases, emphasizing the present need for awareness and understanding in this field. We encourage active participation throughout the webinar. Your engagement is key to making this session enriching and informative for everyone involved. I now request Dr. Apurav Das, the Director of ICMR-NITHR, to welcome address for today's webinar. Your valuable insights would greatly enrich the event, sir. Thank you.
Thank you, Aishwarya. Thank you, Dr. Ravindra Kumar, who is a fellow scientist, for organizing this event. And I would consider that this event is a rare event of the rare genetic disorders. So I have some statistics to tell people that there are about 7,000 diseases which are considered to be rare, which I also didn't know, but today I came to know. And around 350 million people worldwide, they are having some kind of rare disease. 350 million, which is not a rare. And there are about 50% of the babies, they are born with rare disease, they die within a month of time. And if I tell the statistics in India, 1 in 20 Indians are affected by rare diseases. So, which means that about 7 crore of people in India, they suffer from rare diseases, some kind of rare disease. And more than 80% rare diseases are caused by genetic disorder. Like there are some mutations somewhere in the genes of human. They are causing the rare genetic disorder, which we are going to talk about today from different experts from different fields. So as everyone knows that probably not all the faulty genes, they convert into some kind of genetic disorder or genetic diseases, because environment plays a big role in expressing the disease. So not only a person with some kind of faulty gene or mutation in the gene will be converted to a diseased person. So environment has a bigger role to play for the expression of the gene and then bringing that person to a diseased state. We do not actually give that kind of emphasis to these rare diseases, which we should, because we have in India we have so lot of diseases, and we are still struggling to control the most endemic diseases like tuberculosis, malaria, which are affecting many of our population. So it is now time, and this is really timely. And today, actually being the Rare Genetic Disorder Day, we should remember that rare genetic disorders are so important to study and so important to know and to bring to the public health attention that we should have uh, some kind of like treatment for rare genetic disorders. Diagnosis is very important. Once we diagnose people that which kind of genetic disorder one has, and then the preventive aspects of the disease. So prevention and diagnosis and prevention, they constitute the main backbone of by which we can actually control the rare genetic disorders. I am really thankful for the speakers who have agreed. We actually wanted to have it in person. Like the plan was to have all the speakers in Jabalpur, so that we could have done it in our campus. But somehow or the other, we couldn't do that. And these speakers are also there in their own position, and the whole program is online. So I welcome all the speakers and all the participants who have joined from different places. I guess there are more than 1,000 participants now viewing, and actually this says that how many people from different domains of this country, they are interested to know, to understand what are these rare genetic disorders and how those rare genetic disorders can be controlled and can be taken into consideration by public health, and then how those genetic disorders are to be like more research can be done, and then some kind of intervention has to be provided. With this, I welcome you again, everyone, and I wish that the program will actually be successful. I will request everyone that if they can, they should ask questions, and sessions should be much more interactive so that the speakers can also describe detail where the participants will not be able to follow. Thank you so much, Manisha Madam, Namaste, and welcome to this program. I'm really very thankful that you have joined.
Thank you. No,
Thank you.
always a pleasure. Thank you.
Thank you so much. And I really wish this program a success. Thank you.
Thank you, sir. Your welcome speech has set a tone of inspiration and wisdom, providing a meaningful start to our event. I'm delighted to introduce our speaker, Dr. Anupriya Kaur, Associate Professor at ICMR Chandigarh, with around 60 publications having key interest in rare genetic disorders, dysmorphology, molecular genetics, and prenatal genetics. Madam, we eagerly await your insightful lecture. Thank you.
Hello, am I audible?
Yes, ma'am.
Okay. So a very good evening to all of you, and I thank the organizers for giving me this opportunity to speak on this topic. So can we start the talk, please? Ravindra, will you be sharing or I'll be sharing the screen?
Yeah.
So is my screen being shared?
Yes, we can see your screen.
Okay. So
You can switch to presentation mode.
yeah, is it in the presentation mode? Because I can see it in the presentation mode.
Can you move the slides? We are not able to see in the presentation mode.
Is it moving? Yes, now, ma'am?
No, it is not moving.
Okay, then me try to do it again. Is it visible now?
We can see only, means it is not in the presentation mode. So that's a problem, I think.
Ma'am, I am sharing from here.
Okay.
You can stop sharing them.
Lights are visible. Now in presentation mode, ma'am. Hello.
Yeah, Ravindra.
Yeah, slides are visible to you or not?
Yes, just try moving the slides.
Slides are moving.
Yes, now they are moving. Yeah.
Okay.
We're talking about how do we approach adult with an suspected inborn error of metabolism or a neurodevelopmental defect. I'm basically a pediatrician and I have been trained in in medical genetics, and I'm working as a faculty in PGI in the Department of Pediatrics. Next slide, please. So, inborn errors of metabolism, these are characterized by an altered metabolic pathway defect. And although the prevalence of individual inborn errors of metabolism will be very low, but if we club them together, the prevalence according to the literature will be as high as 1 in 800 live births. And the issue or the problem with these disorders is that they are very variable. They are variable in their age of onset, in their way the patient presents to us, and therefore how to approach such cases. And the issues are also that many times we are not familiar since these are rare disorders. And also there are certain specific tests which we need to confirm our suspicion, which are not available in every health center. With this introduction, next slide, please. So, some theoretical aspects. So, we classify these inborn errors of metabolism into three major groups. So the three major groups are the intoxication type of metabolic disorders, or there are energy deficit type of metabolic disorders, or storage types. So by the intoxication disorders, we mean that because the metabolic pathway has been blocked, the substrates which are deposited, they start accumulating and they produce the clinical symptoms. By energy metabolism, we mean that the metabolic pathway was mainly involved in delivering ATP or utilization of ATP by the organelles, and because of this major deficit, there are clinical signs and symptoms. On the other hand, sometimes the pathways are such that complex molecules cannot be broken down properly, and this leads to storage type of metabolic disorders. Next slide, please. So if we look at again this classification, so what are these disorders, as I said? If you can just click on the next slide option. So the complex storage, the class 3, which I said, these disorders clinically, they present with progressive clinical problems. So the disorder is progressively, it increases. There are no waxing, waning courses, and gradually we find that the symptoms that the patient has, they worsen over a period of time. They are not related to any food intake. And what has been seen is that the response to treatment is partial and often quite limited. Next option, please. So these disorders, these group 1 include mainly the lysosomal storage disorders, but then there are other rarer disorders also in this category, like congenital disorders of glycosylation, peroxisomal disorders, etc. Next animation, please. On the other hand, the type 1 intoxication type of metabolic disorders, these include commonly the amino acidopathies, organic acidemias, urea cycle disorders, and disorders which involve the carbohydrate metabolism. So what has been seen in this is, please click on the next option. What has been seen is that these disorders will have a waxing waning course. That is, intermittently the patient will have some problems and then will become normal with some treatment, and then again there will be some episode. And during these episodes, there will be metabolic disturbances. And they, during the period, if they are accurately treated, the toxins, they get removed, and if the metabolic control is good, the long-term outcome may be relatively better. The third category, next option, please. So the third category is that of, please click the next option, is that of the energy deficiency type. So these disorders, examples are disorders of glycogen metabolism or glucose production or lactic acid metabolism, fatty acid oxidation disorders, and mitochondrial disorders. So as one can understand that those organs which have a very high energy requirement, they will be the ones which will be more affected when such a metabolic pathway is involved. So in this, we find that certain organ systems like the heart, the muscles, and mostly the brain, they are more commonly involved. So this type of classification also helps us in clinically trying to classify and narrow down our differential diagnosis. Next slide, please. So as I said, there will be accumulation intermittently, but then specific organs might be affected. Next slide. Next slide, please. Okay, so a staged evaluation always helps. So we say that you should always start with some screening tests. And these screening tests are very simple tests, which should be available in any primary healthcare center, which includes a simple CBC. Look at the hemoglobin level, at the platelet counts, at the total leukocyte counts. Check what is the sugar level like. Are there ketone bodies in the urine, in the blood? Check the ABG, what is the blood glucose, the lactate, and the ammonia levels. So sometimes the screening test is a simple X-ray also. So with this screening tests, we are able to quite possibly suspect a particular category of disorder. But then, as I said, we need to move higher to specialized tests to really find out the etiology. So, example of a specialized test would be what we call as a TMS and a GCMS, or a tandem mass spectrometry, or a gas chromatography and mass spectrometry. And then there are certain further tests which are more specific, which are exactly going to confirm your diagnosis, like doing enzyme assays or doing a genetic testing, which is becoming more and more available these days. So we need to move in a stepwise manner and begin with the screening tests and go towards the specific testing and the exact diagnosis. Next slide, please. So I like to share some examples with which you can have an idea as to how do we day-to-day approach these cases. So for example, this 5-year-old girl child, she presented to us with a very short history. She had probably a viral illness, a fever for short 2 days and cough coryza. This led to poor feeding. She must have a long starvation period. And after that, she had few episodes of vomiting and she collapsed. There was a similar history that at 1.5 years, she had a similar problem and she needed to be hospitalized. So next slide. So whenever a child will in this scenario will come, we'll just check the very basic things. So we found that she had hypoglycemia. Her ABG showed that she had metabolic acidosis and also the ketone levels were elevated. And along with that, the clinical examination showed that she had mild hepatomegaly. She was developmentally normal, and in this particular case, her lactate, her triglycerides, uric acid, they were all normal. But I have mentioned these because in such a scenario, when we find that there is hepatomegaly and there's hypoglycemia, the most common metabolic errors that we see are the glycogen storage disorders and some fructose metabolism defect. Next slide, please. So in this case, so as I said, we can narrow down our differentials by these screening tests that it seems to be this particular type of disorder. She is developmentally normal, but in between she is having these intermittent intoxication type episodes. So we ordered a TMS and a GCMS, and the TMS came out to be normal. The GCMS showed 2 organic acids to be slightly elevated, which could correspond to her ketosis and the lactic acidosis which she had. So it's just correlating with it. However, then we again move to the next level of investigation. That is, we ordered a genetic testing because we were suspecting, primarily in this case, we were suspecting a fructose metabolism defect. And so the genetic report shows that the child was actually carrying 2 mutations which were pathogenic for the gene mutation in the fructose biphosphatase deficiency. So this is quite commonly seen. The good thing is that with more and more education of how to give the diet to avoid prolonged starvation, and as the child grows, the child himself understands that the child should not be fasting for a very long time. So these disorders, they show a good metabolic control and a good overall outcome. Next slide, please. So in this case, so this is one example of fructose. So this is how we approach these, next slide please. So this is how we approach these inborn errors of metabolism that look at the glucose levels, the ammonia, the lactate, the ketone levels. So like in this case, it was pointing towards the glucose metabolism defect. I cannot give you all the examples, but hepatomegaly and like in some disorders like galactosemia, there can be cataract. Some more or less they are neurologically normal, and there are normal in between episodes the patient is normal. I'll come to the other ends of what I have ruled out, but the main idea of this is to show that the screening tests themselves will help you to narrow down and choose between whether it's a urea cycle or a fatty acid or an amino acidopathy, etc. Next slide, please. So this is the second case. This baby boy at 7 months, he presented to us with a history that he has been having multiple episodes of vomiting and poor feeding, and he is also having seizures in between. And whenever his condition deteriorates, he has altered sensorium. He starts having rapid acidotic breathing, and he is not showing normal development. And when we took a detailed family history, we found that there was another sibling of his who had died at an age of around 7 or 8 months with similar presentation. Next slide. So when we further went ahead with the screening test, we found he had thrombocytopenia. So there was mild anemia, but main thing was that there was cytopenia. And the ABG was showing a high anion gap metabolic acidosis. So next slide, please. So now it's showing that there is a high anion gap metabolic acidosis in a child who is also having cytopenias, who is developmentally delayed, and he's having recurrent episodes which are precipitated by illness. So in this case, our differentials move towards an organic acidemia, for which we then need to look at the TMS and the GCMS. So those toxins, those organic acids which are not being metabolized, they form complexes with carnitine, and his propional carnitine levels were quite high, as well as the GCMS, which was showing the various organic acids being released. The combination of these organic acids and the TMS profile was consistent with the biochemical diagnosis of an organic acidemia called as propionic acidemia. Next slide, please. So this was the first case probably which we confirmed molecularly also. So we have developed an in-house panel of few common metabolic disorders. So like in this case, we were suspecting propionic acidemia, which got confirmed. So the child was actually carrying a nonsense variation homozygous known pathogenic variation for propionic acidemia. So now we have a molecular diagnosis as well, which is very helpful for the prenatal diagnosis point of view. So for the next pregnancy, now we know that what is the gene, what is the sequence variation that we have to look for in order to tell that there has been a 25% reoccurrence or not in the subsequent pregnancies of the couple. Next slide, please. So like I said, when you find that there is metabolic acidosis, high anion gap, ketones are high, ammonia may be normal or slightly high, not as high as in urea cycle defects, and the glucose may or may not be low. So this constellation of high anion gap metabolic acidosis with the clinical phenotype of developmental delay, etc., will point us towards organic acidemia. The other common organic acidemias like glutaric acidurias or methylmalonic acidemias, these you will be able to differentiate along based upon the TMS and the GCMS and the final genetic testing diagnosis. Next slide, please. Then this is the case 3 that I wanted to share, that sometimes these disorders, they give us other systemic clues also. So like this 10-year-old girl, she was born out of a consanguineous relationship. She had only mild developmental delay. She was going to school. She was doing average in school. But the parents' main problem was a poor distant vision. So she had very high myopia. And the ophthalmological evaluation, it showed that the lens bilaterally was subluxated. And when we examined her, we found that she did had mild skeletal problems like genu varum and joint laxity, pectus carinatum, etc. Next slide, please. Next slide, please. So in this constellation, that in a child who is having a mild developmental issues with relatively some skeletal problems, but the main thing is that she has subluxated lenses with a high myopia, the first differential that comes in our mind is homocystinuria, homocystinemia. So for this now, we move on to the next test, that is serum homocysteine levels, which will help you to find out that whether the homocysteine is getting increased or not. So in this case, her homocysteine level was as high as 146 micromoles per liter, and the TMS, which showed elevated methionine, which also shows that this homocysteine methionine metabolic pathway is blocked. So we got this molecular confirmation again in this case, which in this particular case, the lab had reported it as a missense variant, but then we looked at the ACMG classification and we found that this is actually a likely pathogenic variant causing homocystinemia in this particular individual. Next slide, please. So in amino acidopathies, sometimes metabolically you might not find any significant problems, but there are other clinical clues. For example, in homocystinuria, like there are ocular problems. In phenylketonuria, there might be some pigmentary clues to the differentials, or like in MSUDs, there can be altered urine odor, etc. So sometimes in general clinical examination and the clinical clues, they help us to narrow down our differential diagnosis. Next slide, please. In this fourth case, I chose because I wanted to show this particular sign. So this boy at 5-month-old who had a history of seizure and developmental delay and had an acute problem of poor feeding and lethargy, he showed some cutaneous findings. So he had seborrheic dermatitis. Next slide, please. And in his flexural areas, we could find eczematous lesions. So whenever we see such lesions in a child who is affected neurodevelopmentally also, we should think of biotinidase deficiency, and you can get a biotinidase level done as well as a gene sequencing to confirm it. The reason why I chose is that this is, if you supplement biotin, then a very good metabolic control and a very good recovery is anticipated. So when we are approaching metabolic disorders, we also keep in mind relatively what are those disorders in which something is doable. So biotinidase deficiency is one metabolic disorder which is said to be very well managed, and a simple biotin tablet supplementation can prevent such problems. And there is a good clinical clue also in majority of the cases, which if we are familiar with, then only we'll be able to pick up these cases. Next slide, please. So these are certain other disorders which are actually clues to IEM on examination. So for example, like biotinidase, even Menkes disease, or even multiple carboxylase deficiency, these show hair and skin problems. Homocystinuria and other rarer sulfite oxidase, they show lens dislocation. Peroxisomal disorders, for that fundus needs to be checked. And then cataract is a clue towards galactosemia or even Loeys. And then the mitochondrial disorders, they are often accompanied with structural brain abnormalities. And similarly, macrocephaly is suggestive of glutaric aciduria or having renal cysts. It makes us suspect Zellweger syndrome. So it's good to remember these clues, because when you see these patients, you have to if you are and you make a good diagnosis. Then just to complete the discussion of IEMs, next slide, please. when to suspect a fatty acid oxidation disorder. So, as I said, these are energy metabolism pathway defects, and the presentations are either a hepatic presentation, like a raise-like illness, that there will be a sudden acute liver failure, transaminitis, and hyperammonemia. And then the other hallmark of fatty acid oxidation disorders are hypoglycemia but no ketone body production. So hypoketotic hypoglycemia. On the other hand, sometimes you may just, so when we approach children with dilated cardiomyopathy or hypertrophic cardiomyopathy, uh, and we approach them from a metabolic point of view, fatty acid oxidation disorders need to be looked into. Sometimes they may be exercise-induced myopathies or rhabdomyolysis also. So it's good to remember as to when to suspect these disorders. Next slide, please. And then finally, the storage type disorders, which I think many of the pediatricians and many of us are aware of these long-term, permanent, progressive storage disorder. So this was one child who the family shared multiple photographs with us, and we could make out that as the child was growing, his face was becoming more and more coarse, as well as next slide, please. As well as his cornea actually was becoming cloudy, and he was showing some visual deterioration. So he had very mild contractures. And so when we see children with coarse facies, with corneal clouding, and with these contractures, the screening test, which I said should be available, can be done in every center, is to do a whole skeletal survey. So a simple skeletal survey will help you to pick the diagnosis of dysostosis multiplex, which will almost make your diagnosis of mucopolysaccharidosis to be quite possible. Next slide, please. So here we can see proximal tapering of the metacarpals, the peaking of the vertebra. Next slide, please. So a J-shaped cella. Next slide. Or pelvis, which shows dysostotic changes. So an awareness of these and understanding of all these skeletal changes will help you to narrow down. So the specific test would be to do an enzyme analysis. And in this case, in this particular case, the enzyme analysis was suggestive of a relatively rarer type, that is a type 6 of MPS. Next slide, please. So my take-home messages are that IEMs are usually underdiagnosed, but they are still an important cause of neonatal and childhood mortality, morbidity, and it's important for all of us to be aware because they mimic very common pediatric illnesses or neonatal illnesses, and therefore we need to have a very high index of suspicion. Simple investigations will help you to classify and also manage these disorders. But whenever we do these simple investigations, we should, it is said that the result of a metabolic investigation will be as good as you send, as good way as of sending these samples. So how to send an ammonia sample, how to collect an ABG sample and process it as fast as possible is very important. And finally, making an accurate diagnosis, no doubt, is important both for treatment as well as genetic counseling purposes. So, with this, this is all that I thought of dealing with in this time period that was allotted to me. Thank you.
Metabolisms and how to go for the diagnosis and to suspect certain cases. Thank you so much, ma'am. Now I invite Dr. Manisha Madhaikar, madam, the director of ICMR-NITH and ICMR's Center for Research Management and Control for Hemoglobinopathies, Chandrapur. Ma'am has been awarded by several awards, more notably the one of the NC Kester Prize for topping the MD exams. And she has been pioneered in developing facilities for phenotypic prenatal diagnosis of PIDs and NIH and making a significant. Dr. Madhaikar was instrumental in establishing the national registries for PID under ICMR with NIH and serving as a nodal center for PID. Her profiling contributions include on 180 articles in index journals and 12 book chapters in national and international. Now I invite Madam to share her expertise to Inborn error of immunities. Over to you, ma'am.
Thank you, Dr. Rabindra, for that kind invitation. And thank you, Dr. Das and Rabindra. It's pleasure to be part of this webinar. I'll be talking to you about inborn errors of immunity, a subject very close to my heart. For those of you who can you see my slides? Hello?
Yes,
they're moving, no? Yeah. Okay. So this is for those of you who do not know, this is our institute located on the busiest KM hospital in Mumbai. It's on the 13th floor, top floor of KM hospital. We have been working in the area of immunodeficiencies, primary immunodeficiencies, now known as inborn errors of immunity, for last more than 15 years. And now we have a center of excellence for primary immunodeficiency diseases and have diagnostic facilities available at this center. So next 15 minutes, I hope that I finish in 15 minutes. I will be sharing with you when do you suspect inborn error of immunity and how do you diagnose them. So inborn errors of immunity are disorders that can result from, these are a big group of disorders. You have nearly 500 diseases. And they may result from either a congenital or an acquired defect. More often, most of the time, it's a genetic defect, which can affect any component of immune system. So there are many genes, nearly 5,000 genes, which are related to functioning of immune system. So as you can understand, we have a lot more to explore and understand in this category. And many of these disorders can either manifest as deficiency of immune system, known as primary immunodeficiency diseases, and some because of exacerbated immune response or immune dysregulation, called as primary immune regulatory disorders, or PIRD, PIRD. So together they are called as inborn errors of immunity. So we have this man, Colonel Bruton, in 1952, first time described the case of first case of primary immunodeficiency. And how did he describe it? He came across a boy who, or an adult who was 19 years that time. He had multiple episodes, I think 19 episodes of sepsis before Colonel Bruton saw him. And every time he used to be given antibiotics and recover and go to another physician. And while investigating this child, he did an serum electrophoresis on this patient, and he observed that there is a simple absence of gamma globulin band. And what he did was then give this patient, he gave concentrated immune serum immunoglobulins, which were available at that time, and the symptoms reversed. So the infection stopped, and it remarkably improved the condition of the child. And he labeled this case as an agammaglobulinemia. And now we know this as an X-linked agammaglobulinemia. We also call this as Bruton's agammaglobulinemia. So after this, over almost 70 years, we have now many diseases in inborn errors of immunity have been described, and majority of them have been described in last 2 decades. And this is largely because of the our ability to rapidly sequence the whole exome and identifying more and more novel mutations in these patients. And currently, we, as I said, we have nearly 500 odd genetic defects which have been categorized into 10 different categories. You have a first category, which is immunodeficiencies affecting cellular and humoral immunity, where you have essentially a T cell defect. And because of that, you can also have an impairment in B cell function. And these patients, I think, one of the most severe forms of immunodeficiency, and many of them manifest as severe combined immunodeficiency, or what we call as KID. Second category is combined immunodeficiency. So you have T cell defects, but they are associated with additional syndromic features. Like if you have DJOS syndrome, you can have cardiac abnormalities. If you have Wiskott-Aldrich syndrome, you can have thrombocytopenia and bleeding, and so on. Then third group is predominantly antibody deficiencies, where your T cells are normal, but the B cell, either the numbers or the functioning is abnormal. And A-gamma globulinemia, which we just saw the first case described, was it comes into this category, that is predominant antibody deficiencies. Then you have fourth category, where you have diseases of immune dysregulation, where you have once excited immune system needs to come back to its basal level. There are two important diseases or categories that we have, subcategories in this immune dysregulation. One is hemophagocytic lymphohistiocytosis, which results from an hyperinflammatory response because you have an NK cell defect, or autoimmune lymphoproliferative defect syndrome, also called as ALPS, where you have fast-mediated apoptosis defects. And these are the diseases which come under immune dysregulation. Then you have defects in the phagocytes. Phagocytes, the number, if their numbers are low, they can cause neutropenia. So you have severe congenital neutropenia. Or you can have functions which are abnormal, like you have chronic granulomatous disease, where your oxidative burst activity is abnormal, and it can result in chronic recurrent infections. Or you can have a leukocyte adhesion deficiency, where leukocytes are not able to migrate to the site of infection. So these are all phagocytic defects. Then you have defects in the innate immune system. These defects typically cause susceptibility to a narrow spectrum of infections, and I'll be coming to this. So you can have susceptibility to only mycobacteria. You don't get other severe infections, and that is called as MSMD. So you have susceptibilities to individual microorganism or class of microorganisms. Then you have autoinflammatory disorders. These are the disorders where you have periodic fever in absence of fever, or autoimmunity or autoantibodies. And these are the diseases which are now increasingly being identified, and we know that genetic basis for these disorders. Then you have complement deficiencies. It can affect any component of complement. You have early complement deficiencies, which can result in autoimmune manifestations like early onset SLE, whereas you have late complement defects, which can result in susceptibility to meningitis or meningococcal infections. Then you have inherited marrow failure syndromes like Fanconi anemia, which have now shown that they also have defect in the immune system, and they come under inherited marrow failure syndromes. And 10th category, which is the most difficult category probably to diagnose, is phenocopies of primary immunodeficiencies, that they can mimic any of these 9 categories, but they do not have an inherited defect. They can be caused because of an acquired problem, either acquired somatic mutation in small proportion of cells and hence difficult to identify, or you can have autoantibodies to the component of immune system, which can lead to these defects. So, as I said, immunodeficiencies is the predominant clinical manifestation in many of these diseases, and they can manifest with infections. Infections can be unusual because of anything unusual. If you find in a child with recurrent infection, you should suspect an underlying immunodeficiency. The infections can be of unusual frequency. So you have repeated episodes of sinopulmonary infections. They can be simple otitis media. But if you have more than 4 or 5 episodes per year, you should be suspecting an underlying antibody deficiency. Similarly, if you have unusual site infections, so you have deep-seated infections, abscesses, you should think of an underlying immunodeficiency. If you have unusual severity, you have a disseminated disease, every patient with ICU admission, requiring an ICU admission with a documented infection is something must be evaluated for an underlying immunodeficiency. Or sometimes unusual organisms. Usually you will not get a problem with BCG infection, a BCG vaccination. But if you have a child who has a disseminated BCG infection, it is something where you must rule out an underlying immunodeficiency. Of course, all this comes when you have ruled out an secondary cause, because secondary causes are more common than primary cause. So whenever you have patient with recurrent infection, first is to rule out secondary causes, especially HIV, and then you will think of an underlying immunodeficiency. Depending on the components of immune system that are defective, the site of infection and the organisms can give you a clue as to what can be an underlying defect. So in a patient with antibody deficiency or a B-cell defect, you have recurrent sinopulmonary infections, and the organisms are the common organisms like pneumococcal H influenza. So they cause recurrent infection, recurrent pneumonias, recurrent meningitis, and these are the patients where you should be suspecting a B-cell defect. If you have a phagocytic defect actually can cause infections because of many multiple organisms. But especially if you have a gram-negative sepsis or you have an invasive aspergillosis, this was our first case of chronic granulomatous disease that we diagnosed, had an sternal abscess because of aspergillosis. So if you have anything unusual growing in a patient which you would otherwise not expect in an immunocompetent individual, you should think of an underlying immunodeficiency. This is a child with leukocyte adhesion deficiency where the neutrophils are unable to travel to the site of infection and they get the superficial ulceration. They have delayed umbilical cord separation and sepsis there. If you have a deep-seated osteomyelitis at very early age, these are the patients where you should be thinking of a phagocytic defect. T-cell defects are like, they may mimic presentation like HIV, where you have CD4 lymphopenia, and these patients have severe infection because of opportunistic organisms. They can get, you can see this child has a disseminated molluscum contagiosum. Molluscum contagiosum in a healthy individual, you may get few lesions and they are self-limiting. But if you have this kind of a persistent infection, you should think. If you have a disseminated BCG, especially skin ulceration or skin deposits because of BCG, these are the patients where you should be thinking of an underlying immunodeficiency. Age of presentation can give you important clues. So some of them may manifest in early neonatal period, as I showed you a case of leukocyte adhesion deficiency. Within first few days, some may manifest are completely normal at birth, but may start manifesting between 2 to 4 months. Typically, severe combined immunodeficiency is manifested at that age. Then antibody deficiency, especially A-gamma globulinemia, between 6 months to 1 year, when the maternal antibodies IgG protection starts going down, that these patients start to manifest. Whereas some patients may manifest after the age of 1 year and some even in adulthood. And this is something even in adults, you should be thinking of an immunodeficiency if you see any unusual infection in adults. So to decide when to investigate in these, we have Jeffrey model criteria. I will not, because we have limited time, I'll not go through these criteria, but these are there, well defined. So if you have common infections, you should look at the numbers that have been suggested in these criteria and take a decision of this investigating. But if you find anything unusual, either in the form of unusual organism, deep-seated infection, unusual severity, that is the time you must be thinking of an immunodeficiency. So you have criteria for pediatric as well as adults, separate criteria, but they are there and you can be referred to. In this, you have one important criteria, that is family history. Both in adults as well as in children, it is very, very important to take a detailed family history, because if you have a family history of a sibling death, the cause may not be known, but if there is a history of sibling death, it strongly suggests an underlying genetic defect. Then, as I said, some defects give you susceptibility to broad range of organisms, whereas there are certain defects which can lead to susceptibility to only certain group of organisms. Like you have MSMD or Mendelian susceptibility to mycobacterial diseases. These are the patients which are susceptible to mycobacterial diseases, especially non-virulent mycobacteria, and they manifest nearly 85%, at least in our country where BCG is given at birth. More than 85% of them will manifest with BCG related infections. Similarly, you have underlying genetic defect identified for severe viral infection, herpes simplex encephalitis, invasive fungal diseases, mucocutaneous candidiasis, and so on. So if you have anything severe, unusual in these infections, or you have recurrent same type of infections, you should be thinking of an underlying immunodeficiency. Now I'll give you one example. This child was referred to Wadia Children's Hospital with the diagnosis of chronic granulomatous disease. And why somebody thought of chronic granulomatous disease? Because he had, you can see he had a BCG adenitis very early in life. He had recurrent episodes of tuberculosis. At the age of 10 years when he had come, he had already received 6-time anti-tubercular treatment. Then he had histoplasmosis, and he had come to us with these kind of small lymph node swelling and a diagnosis of CGD. When we looked at NBT, or we tested for NBT, we realized that the NBT was normal. And that time we didn't have access to next generation sequencing as easily as we have it now. And that was the time our mentor, Dr. Zeenat Karimboy, said that we must biopsy, however small this lymph node looks, we must biopsy and isolate the organism. And to our surprise, we isolated a Salmonella typhi from a lymph node biopsy. So now this Salmonella typhi, if you can see this kind of unusual site for this organism, you must think of an entity called as IL-12 receptor beta 1 gene defect. And this defect can lead to recurrent episodes of susceptibility to mycobacterial diseases, as well as intracellular salmonella, atypical salmonella infections. So this patient was a case of Mendelian susceptibility to mycobacterial diseases because of IL-12 receptor beta 1 defect. So now when we analyzed our patients who were referred to us, because this was a patient which was diagnosed with BCG infection, we looked at our data of 90 patients which were referred to us with complications related to BCG vaccination. We realized that nearly 50% of them have an underlying genetic defect. And if you have a BCGosis or a disseminated BCG, the probability is as high as 87%. And if you have a even if you have a localized disease, nearly 30% or more than 30% of these patients have an underlying immunodeficiency. And many of them have a positive family history. So this is something which is very, very important when you are looking at patients with BCG complications. So these were the infectious complications where you should be suspecting an immunodeficiency. Now coming to immune regulatory diseases, which manifest like either in the form of autoimmunity, which is early onset, multiple autoimmune phenomenon. So you have E1 syndrome, you have autoimmune hemolytic anemia, you have autoimmune neutropenia, you have associated recurrent infections, associated lymphoproliferation, and a family history. These are the situations where patients presenting with autoimmune diseases, you must be thinking of an underlying genetic defect. And patients with autoinflammatory diseases, as I said, patients with periodic fever without demonstrable infection or an autoimmune cause is somebody you must think of an underlying genetic defect. Again, an interesting case. This was a 9-month-old male child who was referred to us with a suspected leukemia. And why was he referred for a leukemia? Because he had total lymphocyte count of more than 90,000. So which is usually less than 10,000. And this child had a massive hepatosplenomegaly. He also had small lymphadenopathy. His peripheral smear looked like a CLL, that is chronic lymphocytic leukemia, which is very, very rare or not seen in children. And so we did his immunophenotype. What, to our surprise, this patient had majority of his cells, lymphocytes, were T cells, and these T cells lacked the marker CD8 and CD4. So they were CD4 and CD8 negative, and they were all TCR alpha beta positive. And when we looked at the literature that time, we realized that these are called as double negative T cells. And double negative T cells, if they are more than 0.5% or of the total lymphocytes, or more than 2.5% of the total lymphocytes, they are suggestive of a disease called autoimmune lymphoproliferative syndrome, or ALPS. So, and instead of being less than 5%, he had almost 98% of the lymphocytes, which were double negative. That time we did not have facility at our institute to investigate the child. So we had sent his sample to a lab in Paris, and we identified an autoimmune lymphoproliferative syndrome caused by this rare mutation, Fas ligand mutation, which actually and it is an homozygous severe form. And this was the first case in world literature manifesting with of Fas ligand gene mutation manifesting with ALPS. So this is something which was very interesting. And now we have many cases which have this genetic defect that we have identified. So now I have shown you different scenarios under which you should be suspecting. Once you suspect, how do you evaluate? So as I said, if the patient has come with infections, rather than empirically treating, it is always advisable to identify microorganisms, be it bacteria, be it viruses. You try and investigate for all the infectious causes as far as possible and identify your organism rather than empirically treating it. So then comes a step of immune evaluation. So you need to evaluate whether there is any defect in the immune system that is predisposing for the clinical or that for recurrent infection. And final confirmation comes with molecular diagnosis. So immunological evaluation begins with simple CBC. You look at your absolute count, your absolute neutrophil count, absolute lymphocyte count, absolute eosinophil counts, absolute monocyte count. If they are grossly low, isolatedly low, that may strongly suggest and give you clue to an underlying immunodeficiency. Next investigation that most commonly done in these patients is looking at immunoglobulin level, largely because 50% of your immunodeficiencies are because of antibody deficiencies. So you must look at IgG, A, M, and E, everything, not just look at isolated IgG, because looking at this may give you a clue that what can be the underlying cause. Because sometimes hyper IgM syndrome, you may have a case of hyper IgM syndrome where your IgM may be normal, but G and A and E will be low. So looking at all the four subsets becomes important. Similarly, for lymphocyte subset analysis, don't look at only CD4, but look at also four T, B, and NK cells together. And beyond that, now we know that only looking at TB and NK cells is not sufficient, and we need an extended lymphocyte phenotype. And at our institute, we are doing we have a 14 antibody panel, which is a screening panel that we are using currently for our primary immunodeficiency disorders, which have an additional marker of CD45RA, and we have IgD, IgM, and HLA-DR, which helps you to identify not only the TB and NK major subsets on T helper and cytotoxic T cells, but also helps you to identify the naive T cell in both TH and TC compartment, as well as double negative T cells. So all this is now currently we are using as an extended lymphocyte panel as a screening assay. Beyond these assays, so if you have abnormal numbers of any of these, that tells you that, okay, that this is the cause for an immunodeficiency, and you can explain that. But if you don't see abnormalities in the numbers, then you have to do additional testing to look at the function. So like for B cells, you can look at immunoglobulins, and beyond immunoglobulins, you can look at specific antibody responses, like antibodies to pneumococcal vaccination, antibodies developed to tetanus vaccination, and so on. So they are called as specific antibody responses that you look at for looking at the function of B cells. Similarly, for T cells, you can do T cell proliferation by stimulating with PHA. So you can do variety of assays beyond the initial screening for, again, knowing which system is abnormal and how do you functionally validate it. You have a specific protein expression also, like you have leukocyte adhesion deficiency. CD18 is the protein which is abnormal or in these neutrophils, and that can be easily detected by flow cytometry. It can give you diagnosis within hours. So some of the assays are specific of looking at protein expression, can give you a very rapid diagnosis. But one has to remember that all proteins not always expressed are going to be functionally normal. So rarely you can have a case where protein expression is normal, but the function of that particular protein is abnormal. Then I said you can have variety of functional assays, like you have this DHR assay or dihydrorhodamine assay, which can look at the function oxidative burst activity in patients with neutrophils or CGD, chronic granulomatous defect. Then downstream signaling. So if you have a particular receptor or a pathway which is defective, you can design specific functional assays to look at the abnormalities in those pathways. Beyond that, we also have some assays which can look at radiation sensitivity, because certain individuals with inborn errors of immunity can have radiation sensitivity along with immunodeficiency. So this is a n number of assays that can be designed or currently available with us for evaluation. But every patient, you will not apply these assays because it is very difficult, because every time for everybody to refer the patient to the institute, as well as it is not advisable to do all the assays in every patient. So very often the patients, the clinicians have to resort to doing a genetic analysis beyond doing after doing initial immunological screening. And this is usually done by resorting to NGS analysis. Of course, there are multiple tools for genetic diagnosis that are available. I will not go into these aspects of what tools to be selected, but it is important that you select the right tool for genetic diagnosis. I'll give you one example. This was a child which was referred to us from Middle East countries. He had BCG adenitis. He had multiple abscesses over the period. So he was actually again symptomatic since childhood. He had invasive pulmonary aspergillosis. And so a classical picture where we had thought that this child has a chronic granulomatous disease. So we did an NBT. You can see that these are the normal neutrophils showing this formazan deposits, whereas in patient, the deposits were absent. He had an abnormal DHR, confirming that he had an oxidative burst defect. But we, the clinicians, because the patient was from outside, were in a hurry and said, had sent a clinical exome outside. We showed that there was no pathogenic mutation identified in CGD-related genes. Now, CGD can be caused by 5 different genes. One is X-linked and other 4 are autosomal recessive. So what we did, we again repeated the DHR. It was abnormal again. Then we looked at the components of NADPH complex. We realized that the patient had a P47 FOX protein, which was abnormal. So this P47 FOX is encoded by NCF1 gene, and which has a pseudogene, and that is the reason why NGS could not pick up this defect. And he had a 2 base pair deletion, which was identified by a different method called a gene scan. So the lesson is that if you have to know the limitations of an NGS, and if you don't identify a mutation, you do not stop there. You need to know why you have not identified a mutation and probably do other investigations to come to diagnosis. So in a last series of 90 patients that we evaluated, nearly 50%, 47% had this same deletion defect, autosomal recessive CGD. So this is very, very important if you're clinically suspecting a CGD. Before you go on to choosing an NGS as a method for diagnosis, look at del-GT mutations. Then coming to my last case, and then I'll end. This was a female who had 35-year-old female who had presented at Wadia Children's Hospital with multiple episodes. Means right from birth, she has been ill, recurrent, visiting hospitals multiple times with respiratory tract infections, otitis media, stomatitis, sepsis. She had this very bad oral ulcerations which are recurrent, and she had a neutrophil count which was very low. So she had neutropenia, for which marrow was done, which showed a maturational arrest of the neutrophil. So she had a congenital neutropenia, where we did an NGS and identified a mutation in a very rare gene called G6PC3. This gene, however, genetic defect, when the clinicians from Wadia Children's Hospital read up about this gene, they realized that it is because of an accumulation of a toxic metabolite in the neutrophil precursors in this patient. And in mice, there were studies which had shown that if you use a SLG2 inhibitor, which is an anti-diabetic drug, it rescues the myelopoiesis. And because of these mice studies, then this particular anti-diabetic drug was tried in this patient, and which completely reversed the clinical phenotype of the patient. And now the patient is without major symptoms, and simple 1 tablet or oral tablet per day. So this is a story which probably is going to be more common. More and more genetic defects are identified. Probably we'll have more and more targeted therapies. And that is why identifying a defect, even if the symptoms are common, becomes very, very important. This is just to tell you our data. We had a center of excellence, so we evaluated almost 10,000 patients till now. and identified a cohort of thousands of such patients. And we have variety of cases in almost all categories of immunodeficiency, just to tell you that immunodeficiencies are not uncommon diseases. And now we have publications for almost all the important major cohorts, and anybody wants to refer to understand the ways of diagnosis, spectrum of these diseases from India, you can refer to these publications that we have. So to summarize, IEIs are not uncommon. The collective prevalence can be as high as 1 in 500 and hence must be suspected. The most important step in diagnosis of IEI is to think of IEI. Once you think that there is something unusual in this patient, apart from a just simple infection, you will find out ways and means of diagnosing it. Now you have availability of flow cytometric test. NGS is now relatively easily available for almost all the patients across India, which has actually improved the diagnosis of primary immunodeficiency significantly over last few years. Early diagnosis, as I said, can reduce morbidity and mortality. Now, when we started in 2006, we had all patients, 100% mortality or severe combined immunodeficiencies. Now, within India, within Mumbai, we have 4 centers in the public hospitals. We are providing bone marrow transplantation for primary immunodeficiencies, and these are now curable. So now, if you diagnose them early, there are means of cure in them, and more patients can also be treated with targeted or specific therapies depending on what defect they have. So it is the interaction between clinicians, immunologists, and geneticists, which is very, very rare, important, especially when you come across a rare or an unresolved case. And once you identify a genetic defect, it must be followed by genetic counseling, because still we see that patient, even if they have one death in the family, the subsequent siblings are still affected. Even if you've diagnosed a specific immunodeficiency, that is somewhere we are lacking, that we are not conveying or adequately doing a genetic counseling. So this is important for probably all genetic diseases, that you must remember that if you have diagnosed one case, subsequent deaths should be prevented with adequate prenatal counseling and prenatal diagnosis. And I will stop here once again. Thank you very much for the opportunity. I'm not sure whether I have exceeded the time, but if I have, I'm sorry for that. Thank you.
Thank you so much for enlightening us. This is a very wonderful presentation, and from the types of the immunity to the case-based discussion for how to approach for the diagnosis for the Inborn ILR community. Thank you so much, ma'am.
Thank you. Thank you.
Now I invite Dr. Kaushik Mandal, sir, additional professor at HGPGIMS Lucknow. He has expertise in dysmorphology and pediatric genetic disorder and genetic counseling. His ongoing research spans the lysosomal storage disorders, genetic and hematological disorders, and inherited kidney diseases. He has around 85 publications and 7 chapters and contributions to the London dysmorphology databases. Now, over to you, sir, for giving us how to approach for genetic disorder diagnosis and management.
Can you see my slide, Ravindra?
Yes, sir. We can see your slide.
Great. So, carrying the thread of Dr. Manisha, it's a multidisciplinary approach for all disorders, and genetic disorders are not rare. So I often use this cartoon to show people that once upon a time, my mother used to scold me that you are not doing anything correct.
Slide.
And so it's not moving.
Yes, sir.
It's not moving.
Okay.
You can't see slides.
I can see only the first slide, genetic disorder diagnosis.
So please put it in the slideshow mode. It's not in the slideshow mode right now.
No, it is.
No, it's not seen in the slideshow mode.
Now?
No.
maybe I will share the entire screen. Is it visible now?
I did slideshow mode.
Is it visible in the slideshow mode now?
Yes.
Yes, yes.
Okay, thank you. So maybe, so I often use this cartoon to show that my mother used to scold me that you don't do anything correct. And my wife tells me now, my mother is replaced by my wife, and she tells me that you are better as a pediatrician. And what are you doing as a geneticist? There are no treatment for genetic disorders. So can I be excused for 1 minute? But I always keep on telling that yes, there are treatment for genetic disorders. So in the few more slides, I will be telling about. So can you hear me and see my slides?
Yes, yes.
Okay.
Yes, sir.
Thank you. So carry on to carry on with the threads of Dr. Manisha, which she has told us that it is a multidisciplinary approach. Not everybody can provide every service, and it is absolutely impossible to tell you what are the different genetic disorders and how to touch up everything in this time. Even I haven't learned everything. So, but we have to know that genetic disorders, and to deal with genetic disorders, we require scientists, we require therapists, we require the diagnostic testing team, we require genetic counseling, we require pediatricians, and it's a multidisciplinary team for all disorders. So what I will try is to tell you about few genetic disorders in each categories. Like many of you must be working with chromosomal disorders, many of you must be working with single gene disorders, like some of our speakers, some are working on immunity disorders, some are working on neurogenetic disorders, so some are working on metabolic disorders. So it is sometimes very difficult to touch up everything. But what I will do is that in each category, I will try to explain some live lessons and present some cases so that after I finish of my talk, some notion is being carried throughout. So why it is important to know about dysmorphology diagnosis, why it is important to know the genetic disorder, what is it, it's important to go in depth of it is that the burden is high and it's a concern, it's a stigma to the family. And getting to the bottom of it is important to predict the outcome, the recurrence risk, and definitely there are management. So this baby I have seen when I was practicing as a clinical geneticist before I joined the faculty position here, maybe 12 years back. And this baby was born with a diagnosis of esophageal atresia. Esophageal atresia means the esophagus is atretic and it is something which is surgically correctable. But this baby had some dysmorphic features for which our neonatologist called me and told Kaushik, can you find out whether we should ventilate this child, whether the parents should go for very aggressive treatment, whether a surgery should be taken up. The the pediatric surgeon told me, Kaushik, something is wrong. So I told, okay, yes, there are certain features which fits into either trisomy 18, or it's something called triploidy, where the feet looks very similar, the eyes are very similar with blepharophimosis. And in both these disorders, the babies are the babies are very small, and they have severe intellectual disability, global developmental delay. These are other babies with trisomy 18. So pediatrician can easily pick up this type of hand where the middle finger is overlapped by the other digits. and this toe or the feet, which looks like this. The small eyes is called blepharophimosis. So what we did is a fish for a rapid diagnosis, and you can see here, this is a karyotyping where you can see all chromosomes which are in pairs except for 18. This is trisomy 18, and we have proven it. First, we did a fish for a rapid diagnosis, and the parents can be counseled that yes, the outcome is very, very poor. So it is up to you whether you need a very aggressive treatment or you just want a palliative treatment for this child for survival for whatever time the baby survives. So this fish is a rapid method, and what we did is a fish first followed by a karyotype. This is another case scenario. You can see a newborn with a large nose and a cleft palate. The baby also had hypocalcemia. So a clinician, a pediatrician or a geneticist who is straight away told that this is velocardiofacial syndrome. You can see this is an adult who has a similar pear-shaped nose. They might have very mild intellectual disability, but they have a heart disease. So we look for the heart in them. So this is velocardiofacial. And again, what we do is either an interstitial fish like this, where you can see that there is targeted fish. This is the chromosome 22. And this is the region which is deleted in one of the chromosomes, or we do a MLPA. So these are microdeletion syndromes. So the first group of disorders are chromosomal disorders where there are number and structural defects of chromosome. These are called microdeletion syndromes or microduplication syndromes in some of them. And these are various common microdeletion syndromes. So this is Angelman syndrome, also called the happy puppet syndrome. This is Prader-Willi syndrome, where the child is extremely obese. So they have their own set of difficulties, and we as clinical geneticists help the family to go through various occupational therapists, physiotherapists, and assessments, their dietary therapies, to various other subspecialties of pediatrics so that their needs are taken care of. This is a child with Williams syndrome. These both of them have Williams syndrome. Again, all of them are microdeletion syndromes. They are interstitial or small deletions. So when I saw this child, the baby had this large metopic suture and had developmental delay. But there was no family history of similar disorder in the family. The baby was operated for imperforate anus in the neonatal period. So what I did, you can see these thumbs which are small, these great toes which are again small, and a small mouth and a prominent forehead, that is a metopic ridge. So what I did is that I searched the databases, various databases, to find out what can be the mix and matches. There was also something called agenesis of corpus callosum or a mild form of holoprosencephaly. So what I searched are hypoplastic thumb, metopic ridge, imperforate anus, holoprosencephaly, developmental delay, and what I hit was a Barrett-Gerald syndrome, which is autosomal recessive condition. I told the parents that your child probably has a single gene disorder, and they were consanguineously married or maybe married in a very close community. So I told them that probably your child has an autosomal recessive condition, but let us do step by step. So we worked on the step, and karyotype was done as a part of the investigation. And here you can see this is a normal 13, and this is the 13 where part of it is deleted, right? Part of it is deleted. So this is 13q deletion in a karyotype, which we can see here. So when we saw the baby, and it also fitted into 13q deletion, and you see that these are the genes responsible for whatever phenotype we have in the child. SIC2 is a gene which is distal to the deletion and responsible for the holoprosencephaly. And GPC5, this is another gene which is expressed in the mesenchyme of the developing limp bud, for which the child had hypoplastic thumb and hypoplastic toes. But remember that it is important to know the disorder and the area of deletion, because RB1 gene was proximal to that. Had RB1 gene being involved, so RB1 is retinoblastoma, we should have put the child on surveillance for retinoblastoma. So what I learned from here is that systemic evaluation is more important than a smart diagnosis. What I did initially was a smart diagnosis. I searched databases and found out the diagnosis, told the parents that your child has this. But I went through a systemic evaluation and has found very, very different disease, and all the phenotypes will match into that. So in dysmorphology diagnosis, it is important that we fit in and try to fit in and go systematically for all works. This child, who is a 12-year-old female child, poorly built and poor weight gain, extremely thin body habitus, abnormally long and apparently disfigured bones. So again, what we thought is probably a variety of Marfan syndrome. You all know that Marfan are thin and long. Please excuse me for 1 minute. Can you hear me? Can you see me?
Yes, sir.
Okay. So we saw this girl who has this very peculiar face, and there are bony prominences which are actually dislocations, these thin fingers. So we thought it is a part of probably or a variety of Marfan syndrome, but Marfan syndrome do not have intellectual disability. So you can see the hands, you can see this arachnodactyly type hands. You can see the fit, and these are few signs which we do for Marfan syndrome. So they were all matching, but her height was not that much, which is unusual for Marfan, and her head circumference was also okay, but she had intellectual disability. There were some echo findings. Again, somewhat it fits into Marfan, but X-ray had shown elbow dislocation and angulation of sternum. So when we have tried to fit in all these features, it's fitted into a disorder called Spindgen-Goldberg. So now when I see a Spindgen-Goldberg, we can easily diagnose a child with Spindgen-Goldberg syndrome. It is a craniosynostosis syndrome with joint dislocations. This is called a gene called SCY. There are few exons. We have actually sequenced and found two different variations. One of them was actually pathogenic, the other was not. And we had to prove whether this was in cis or is in trans, right? So we did in the mother and father, same areas. So father had both, father and mother were not having the disorders, not having this both variations. So both are de novo in this child, and both are in cis. So to prove that, what we should have done is cloning. We did some protein modeling, and we did some cis trans testing. We did it to a restriction enzyme. So one of these actually, when it is there, it creates a restriction site, and it can be cut into two different halves when it is present. And what we did that once putting it in restriction, we sequenced this fragment and found that both the sequence changes are in the same fragment in the child or in the person with this disorder. So we proved that they are in the cis, that is both of them in the same allele. So knowledge is never wasted. We don't use the restriction fragment length at all at present, but we had been using it many years back. But that knowledge we have put in this. This is a child again with developmental delay who presented with blindness, mild sensory neural deafness, and areas of unusual skin coloring. You can see this baldness in the temporal area. That means in the area of the head where there is very lack of hair. So again, I went systematically, but I knew what the diagnosis might be. So blood karyotype was normal. it fitted into something called a Pallister-Killian syndrome, where there is tetrasomy of 12p. So 12p is increased, or there is duplication. There is duplication of chromosome 12p. What we did, that we did a skin biopsy and did a karyotype from the skin. You can see that this is a marker chromosome. Marker chromosome means where a chromosome cannot be fit into any of these chromosomes. But I knew that this is 12p duplicated. So you see that how does the p arm of 12 looks like. So when it gets duplicated, then it must be looking like this. So this is tetrasomy of 12p and called Pallister-Killian. So to prove this, what I did is that we extracted DNA from that skin. So this is a disorder where this mosaicism, there is a mosaicism of 12p, a tetrasomy of 12p, and it goes away from blood. But it remains in certain tissues like skin fibroblast, and we can prove it like this. So what I did, we extracted DNA. And we did a MLPA, and you can see that this is 12p, this is 12p, and you can see that there is duplication. It is something between 1.5 to 2. The ratio between 1.5 to 2 means there is some amount of mosaicism here as well. And we can actually prove that it is 12p tetrasomy or Pallister-Killian syndrome. So when we saw another child with similar disorder, you can see that the face is like that. There is blindness. They have severe developmental delay. Again, we did a skin biopsy and proven that you see that same type of marker chromosome, which is like 12p, is present from the skin fibroblast, and the diagnosis is 12p syndrome. So what the mind does not know, the eyes cannot see. So if you have not, even if you have done an NGS, you would not have diagnosed this disorder. So when we suspect such disorders, then only we can think that yes, we have to do a skin biopsy, do a karyotype. Then to prove that this is a part of this chromosome, we can do another test. But first we have to suspect it and do. Neither a microarray from blood, neither an NGS from blood would have picked it up, right? So this is something which we learn with time, that our mind needs to be trained so that our eyes can see and suspect. These are males with LSD, lysosomal storage disorder. Dr. Anupriya has discussed few of them. They are large molecule disorders. So typically what happens, that two males are affected. There are two of them, two brothers, they are affected. And they will have distant family history of from the mother's side, where another male might be affected with similar disorder. So this is a typical X-linked disorder. And this is mucopolysaccharidosis type 2 or Hunter syndrome. These are the features. They have umbilical hernia, they have contractures of limbs. These are typical bullet-shaped phalanges, this proximal tapering of metacarpals. They might have hearing deficit, they have short stretcher. So this is our cohort of patients which we had seen and published in 2016. These are typical X-rays. For all these disorders, we can see the X-rays and categorize or subcategorize this disorder, so that we do a enzyme assay or straight away do a molecular testing for this. So for this, what we did is actually Sanger sequencing. We do this gene by Sanger sequencing, and more than 80% are sequence variations. These are the various clinical features. What we see is short stature, respiratory symptoms. Most of these children present to the ENT specialist for their adenoids, their noisy breathing, they have macrocephaly, umbilical hernia, they have large liver and spleen, they have joint contractures, and many of them might have intellectual disability. So this is the disorder which is very variant, but their clinical picture, their X-rays are very, very typical, and you can typical of this disorder, and you can pinpoint that this is disorder. Either you do an enzyme assay or we do a molecular testing after the enzyme assay. So by molecular testing, we do Sanger. In Sanger, we design primers in the exon intron boundaries, amplify them exon by exon, and see each exon from the forward and the reverse. These are the peaks which we see, that the chromatograms, and we can have a reference sequence to find out what were the mutations here. And for their treatment and evaluation, again, we have a multidisciplinary team because they have respiratory problems. We have pulmonologists and ENT people. We have they have cardiac problems, so we have our cardiologist. We have our developmental assessment team. We have our neurologist and neurosurgeons. Sometimes they require carpal tunnel. They might develop carpal tunnel syndrome and they require a release of that carpal tunnel syndrome. We need neurosurgeons. Sometimes they require shunting for their hydrocephalus, which they have, and definitely a pediatric surgeon who is a very good friend of mine who operates on their different hernias. So it is a multidisciplinary team to treat these children. Not that every time we give enzyme replacement therapy, though we have some children on enzyme replacement therapy, and enzyme replacement therapy is very, very helpful in most of them. So the so the liver size decreases with time, the spleen size decreases with time, the 6-minute walk test, that means the endurance of work improves with time with enzyme replacement therapy. See, this is the two brothers where I have started with. One of the brother received therapy because the therapies are very, very costly. Enzyme replacement therapy is very, very costly. So he improved with time in 8 to 10 years now. And last month we lost his elder brother in illness because survival is the major thing which is required, and enzyme replacement definitely improves survival. And infant with hypothermia, you think of Pompe, which is a lysosomal storage disorder. You also think of spinomuscular atrophy, which is very, very common. And now you know that 12 crore or 18 crore drug, which has come in picture in the newspapers, that gene therapy is also available. But what we give is intrathecal nusinersen. The test methodology again is MLPA. And you see that homozygous deletion is found in these children of spinal muscular atrophy of exon 7 and 8. There is easy diagnosis. We have it with us. And the copy number of SMN2, which is a very similar gene like SMN1. The copy number of SMN2 dictates whether the child have a mild phenotype or a very severe phenotype. So if there are a large number of copy numbers are more of SMN2, they have attenuated phenotype. The chances of survival, the chances of sitting, walking is more if they have SMN2. So with MLPA, we diagnose them, and we have a fairly, definitely it is clinical, which is SMN type 1 means those who don't sit and their symptoms come before 6 months of SMN type 2 means they will sit, but they will never work. SMN type 3 will walk. Sometimes we have 4, sometimes we have 0, where the symptoms are intrauterine, but broadly it is classified on type 1, 2, and 3 according to severity, 1 being more severe and 3 being least severe. So carriers, again, carrier status can be looked like this. You see that they have half the copy number of SMN1 where they are carriers. So when 2 carriers marry, they will have children with SMA. So it's a common cause of floppy infant, and homozygous deletion of exon 7 and 8 of SMN1 gene is detected by MLPA. Also detects MLPA also detects carriers. So universal screening of SMA is advisable now for every pregnancy who come, like we screen for beta thalassemia, we screen them also. And these are the various drugs. There are oral small molecules. There are ASO, which is nusinersen, which is marketed as Spinraza and given intrathecal, that means in the spine, in the spinal cord. And there is also gene therapy. So I will not go for gene therapy, and we will not discuss so much about gene therapy, but the drug which we give is Spinraza. It improves, actually corrects a very small defect, and the SMN2 gene starts functioning and starts producing full length protein like SMN1, and SMN1 also get somewhat corrected. And there are long-term studies which tells that this drug is helpful. So we have recruited this number of patients, and we have got for some, this is the drug which looks like this, and we give it, you see, in the spine through intrathecal. First we'll put a needle, like we are putting a needle inside the spine. This is eye only. So when we started a few years back, we started putting it. You can see that we are putting a needle, and we'll start draining the CSF. So when CSF gets drained, that means it is in the spine. So you see that it is draining. So we'll collect some amount of CSF and we'll inject the other part. So we need to be very, very sterile when it comes. Then only we'll. So we'll tell that touch mat karo. And then we have so once we go into the spine, we'll have this drug loaded. This is very, very costly, around 12 crores a year during the loading at least. And we are getting this free of cost from the company. Then we'll inject gradually inside the spine. And it is definitely very, see, this is a child with type 1. This is the child with type 1 who is only moving her limbs and in the plane of the bed. And after loading, doses have been completed. And she started sitting. So a child with type 1 will never sit. But see, this drug helps, and she started sitting. And recently, she started walking with holding furnitures. And what most important is that the respiratory symptoms are taken care of. Otherwise, all these children with type 1, they die of respiratory failure. So this is one child who was able to sit, but with nusinersen therapy, she can drag herself to the bed and she can walk also. So people come from very far. There are some other genetic disorders which we treat apart from these, like beta thalassemia, you know, it's treatable with bone marrow transplant or therapy with blood. We need to chelate iron for them. We treat hemophilia A and B. Again, we have factors, we have recombinant factors, and there are drugs which can bypass if there is an inhibitor. We also treat osteogenesis imperfecta, some other metabolic disorders as well, like hepatic GSDs, glycogen storage disease. What they require are just corn flour to have a good glycemic control. And we have our pediatric gastroenterologist to take care of various other things which are associated with GSD type 1. This is one very interesting child or a very interesting patient who came with neuroregression and is unable to move. He can barely move in the plane of the bed. There were some differential diagnosis, definitely not an SMA, because we didn't do a SMA also, because he did not have that amount of hypotonia, but there were dystonias. So there were some differential diagnosis, and NGS has given us the answer. He had dopa responsive dystonia, and dopamine is an oral drug. And once we started dopamine, you can see that he started sitting. He now comes to me. Previously he didn't used to talk also nicely. Now he started talking fairly well and started sitting. And recently when he came to me, he started walking, which was just with an oral drug, because we could make the diagnosis. So genetic disorders are definitely treatable. He started walking well, and when they are untreatable, or even some of them are even being treatable, sometimes treatment is very, very difficult for some families, some children. Getting the drugs are not that easy, like we got it for dopa responsive dystonia. Like for everything else, we have MasterCard for anything where diagnosis is made molecularly in the child. We have prenatal testing, so we do prenatal testing. This is a CVS where we take the sample from the chorionic villus, or we take amniotic fluid when the pregnancy has advanced, and amniotic fluid has the advantage of growing good chromosomes. CVS has the advantage of having good amount of DNA. We do prenatal testing in our setup. So the take-home messages are each patient and each test gives us opportunity to learn. A systemic evaluation is better than a smart diagnosis. Knowledge is never wasted. What we have learned someday, we'll make it some other day. What the mind does not know, the eyes cannot see. And treatment management of genetic disorder is a reality, but it's a teamwork. A single person cannot do it. We have to do a teamwork. So this is our team. This is our older team where we have learned and worked. This is our present team, where we have our faculty, residents, and other lab members as well. So this is Shashank, who does most of the molecular tests for me, and this is Priyanka, who was there with us. Now she is in PGI Chandigarh, who taught me molecular tests. Thanks to the organizers, Director Sir, Ravinder, who has given me this opportunity, my patients who made me learn, my colleagues and different departments of our institute and our institute, and my friends who ride motorcycle with me. Thank you so much.
Thank you so much, sir, for enlightening and giving a take-home message that systematic evaluation is more important than smart diagnosis. Before inviting our next speaker, I would like to say all the speakers that turn on the video so that we can take a photographs of all these speakers here for 1 minute, and then. So I request all these speakers to turn on their video. Dr. Kaushik, sir. Bhavna, ma'am. Anupriya, madam. Yeah, thank you.
Hello.
Thank you, ma'am. Now I invite our next speaker, Dr. Bhavna Dengra. And as we see that Dr. Kaushik's lecture, that the diagnosis and management is possible, and rare genetic disorder is common. So I invite Dr. Dengra, and she is a professor of pediatric at IIMS Bhopal, and authored around 28 book chapters and 57 research publications. And Dr. Dengra heads a subcommittee of hemoglobinopathies and RBC disorders for India Pediatric Hematology Oncology Group. Her focus is on newborn screening for hemoglobinopathies and showcase her commitment to critical healthcare. Now I invite Dr. Dengra to talk upon the national policy of rare genetic disorder.
Are my slides visible? Good evening, everyone. Not yet.
Not yet. If there is a problem, I can share slide from here.
I think I have sent the PPT to you. You can share it.
Slides are visible.
Yes, I can see the slides. I hope everyone else can see the slides.
Yes, we can. Mhm.
Okay.
But
So,
it's not in the slideshow modes.
Dr. Ravindra, you will need to.
Hello.
Hello, can I start?
Yes, ma'am.
Yeah. Okay. So, talking about national policies for rare disease, all of us know that the last day of February is commemorated or observed as the globally as the Rare Disease Day. So today, on this Rare Disease Day, we all are aware of the fact that when we say rare diseases, these diseases individually may be rare, but the cumulative burden or the health impact that they have globally is huge. And to address this huge impact, a clear-cut policy or guideline was required to deal with the impact on a national level and to have standard treatment guidelines or policies for management of individuals and families affected with these disorders. So we collectively know that these rare disorders are not rare and they contribute a significant amount of burden to the morbidity and mortality related to medical conditions. So as in 2017, the government Ministry of Health and Family Welfare, Government of India, shared the first draft of the national policy for rare diseases. And this draft brought states on board, and there was an upper limit for government support, which was set in the tertiary care setup to the tune of maximum of 20 lakhs initially. The model then proposed was expenditure sharing between the center and the state, following which this policy was put up in the open domain for comments and suggestions for everyone. Later, this was a wider consultation and recommendations to reframe the policy were obtained, and an expert committee was constituted by the MOHFW. This committee has given the revised policy document, which was released in 2021. So as far as the definition of rare disease is concerned, all of us are aware that globally there are different definitions which different countries are following, and there is no standard clear-cut definition. And India still does not have a clear definition for rare diseases. WHO defines them as a debilitating or a lifelong disease or disorder with a prevalence of 1 or less per 1,000 population. So 1 in 1,000 is the cutoff which WHO has taken. Now these disorders, this is not a single disorder. These are a heterogeneous and diverse group, and more disorders are being added every day to this pool. As of now, more than 8,000 disorders have been recognized as rare disorders. And since we do not have robust epidemiological data on the exact prevalence of these disorders, therefore, there is a complete lack of holistic and comprehensive approach towards diagnostic and management options for these disorders as well. As you can see that the definition varies from various geographical locations. Population of 6.4 per 10,000 population. Europe has a cutoff of 5 per 10,000. Japan and South Korea have a cutoff of 4 per 10,000, while Australia and Taiwan have defined it as a cutoff of 1 per 10,000, less than 1 per 10,000 population. Now, why addressing these issues is important is because all of us know that there is a huge time lag between diagnosis of from the clinical presentation of the patient and the diagnosis of these rare disorders. As long as 7 to 8 physicians the patient might have met before a final diagnosis is given, and this odyssey might have taken somewhere between 4 to 5 years, leading to a, and still some patients may not receive a complete diagnosis. So what are the challenges that we are facing with rare disorders is that there is a lack of robust epidemiological data. So the exact burden and the impact on the economy and the expenditure being incurred on these disorders is not known. And since we do not know the exact burden, allocation of resources from the government itself becomes a challenge. Now, for these disorders, not for all disorders, therapeutic options are available. Only for 5% of the diagnosed conditions, we have therapeutic options which are available. So there is a prohibitive cost of treatment. The treatment is not easily accessible, and the sustainability of treatment again becomes an issue. So the first step towards having a policy was to generate an epidemiological data. Now, how do you generate this data? So parallel effects from the ICMR by creating a hospital-based national registry for rare disorders were undertaken, and centers across the country. There are 7 nodal centers and then reporting centers across the country which are reporting in the rare disease, National Rare Disease Registry regarding the conditions which are being diagnosed according to a structured format. Now, the allocation of resources towards these disorders again becomes a challenge because still we have a huge burden of public health problems like pneumonias and diarrheas. So there are competing interests within a resource constrained setting. As per this policy now, the group of disorders have been classified into 3 groups of disorders. First group of disorders is those which are amenable to one-time curative treatment. This one-time curative treatment could be in the form of hematopoietic stem cell transplant, liver transplant, renal transplant, or there are conditions which might require a combined liver or renal transplant. So hematopoietic stem cell transplant, for example, some of the lysosomal storage disorders where ERT is presently not available and severe presentation within the first 2 years of age or infancy. Early stages of adrenoleukodystrophies, IEIs like SCID, CGD, Wiskott-Aldrich syndrome, osteopetrosis, Fanconi anemia, all these disorders which can be cured by bone marrow or hematopoietic stem cell transplant. Other disorders could be wherein liver transplant will be helpful or a renal transplant may be helpful. So for example, tyrosinemia, GSDs, urea cycle disorders, organic acidemias, which are amenable to liver transplant, and conditions like Fabry disease or autosomal recessive polycystic kidney disease, which can be undertaken for renal transplant, and some conditions where combined liver and renal transplant may be required. So these are treatable by one-time curative treatment. The second group of disorders is disorders which require long-term or lifelong treatment, which with relatively lower cost of treatment, and benefit is documented with annual or more frequent surveillance required. So conditions which can be managed by some dietary supplements or by providing special diet formulas or food. For example, phenylketonurias, organic acidemias, tyrosinemia, homocystinuria, methylmalonic acidemia, propionic acidemias, galactosemia. All these disorders can be treated or the patients can be rehabilitated with use of food for special medical purposes. And the other disorders are which are amenable to other forms of therapy like hormone or specific drug. Like we know nitisinone for tyrosinemia, bisphosphonate therapy for osteogenesis imperfecta, or pancreatic enzyme supplement for growth hormone deficiency, IVIGs for immune deficiency disorders. So these are all come under the group 2 disorders. Other examples being like hemin for acute intermittent porphyrias, large neutral amino acids, mitochondrial cocktail therapy. And the third group which is there is diseases for which definitive treatment is available, but the problem or the challenge is to make optimal patient selection for benefit, and they require lifelong therapy which incurs a huge cost. So diseases like Gaucher disease type 1 and 3, where there is not significant neurological involvement, MPS type 1, MPS type 2 attenuated forms, Pompe disease, Fabry, MPS 4A and 6. And the other subset of patients under this group 3 included is disorders where cost of treatment is prohibitively high, when long-term follow-up literature is still awaited or is available only for a very small number of patients from selected centers. So like potentiators in cystic fibrosis, use of ASO or exon skipping therapies in DMD, SMA, Wolman disease, hypophosphatemia, and neuronal steroid lipofuscinosis. So these are all disorders under group 3. Now, clear understanding of a rare disorder in under which group it is falling is important so as to know what kind of therapy that the patient will require. So coming to the rare disease policy, it provides financial support of up to 50 lakhs, and now all these are eligible for receiving a financial support of up to 50 lakhs from the government of India. The implementing partners or the agencies for this national rare disease policies are government agencies like DHR, DBT, CSIR, development of newer drugs under the CDSCO, Ministry of Finance, all public sector undertakings, and very importantly, a very crucial role being played by the patient support groups who will help us understand in clear cut burden of the disease also and ideal selection of the patients also for getting benefit under this policy. Now, what are the recent changes or highlights of this policies? That initially 43 disorders were included, but in the last 3 or 4 years, 9 more rare disorders have been identified. A digital portal has been launched for crowdfunding and voluntary donations. Exemption on basic custom duty and GST has been granted on the imported drugs by the Revenue Department. Promotion of indigenous drug production and involvement of Janaushadhi Kendras has been taken up. Financial support, as I said, up to 50 lakhs from Government of India has been provided. And there has been a constitution of Central Technical Committee for Rare Diseases and a national consortium for research and development on therapeutics for rare diseases. So what the National Rare Disease Policy encompasses or envisions is that we should be able to provide integrated and comprehensive preventive strategy for preventing birth of individuals affected with rare disorders. Now, this counseling could be offered in the premarital or postmarital phase, preconception and post-conception screening, counseling programs to prevent birth of children with rare diseases. And again, as I said earlier, we need to balance this within the constraint on resources and competing healthcare priorities. So how can we help, or how does the policy aim to help in prevention of rare disorders? So primary prevention can be by avoiding pregnancy in advanced stage, or rare monogenic disorders like sickle cell or thalassemia by a carrier not marrying a carrier, or carrier couples deciding not to reproduce. But there are feasibility challenges associated with the primary prevention, considering the huge burden of population that we have. So an alternative suggested is to have a simple checklist which is made available to primary healthcare providers to identify at-risk couples based on the inheritance of disease or history of a previous sib or family member being affected, and then identifying carrier screening and cascade screening in the other family members. So secondary prevention in families where there is already a history of having an affected family member could be by avoiding the birth of an affected fetus by offering option of prenatal diagnosis and screening, early postnatal detection of disorder by newborn screening and institution of corrective measures at the earliest, appropriate medical intervention to minimize the manifestations or the effects of the or complications of the disease, and tertiary prevention by provision of better care and medical rehabilitation to the rare disease patients who are presenting in the advanced stages of a disorder. So having a multidisciplinary team to help these patients where a cure may not be available, but symptomatic and supportive multidisciplinary treatment can probably improve their quality of life. So early developmental assessment and provision of early stimulation, occupational therapy, behavioral intervention, physical therapy, rehabilitation, provision of aids, and emotional and psychological support to the affected individuals and families all form an important component of the multidisciplinary effort that these rare disorders require. Now, how this policy is being implemented is that the MOHFW has identified 12 centers of excellence where comprehensive facilities for management of rare disorders are available. So in the first phase, there were 8 centers which were identified. 4 more have recently been added in the last 2 years to the list, to taking the total to 12. Another component which complements these centers of excellence is establishing Nidan Kendras. Now, these Nidan Kendras are diagnostic facilities with tests available for diagnosis of common genetic disorders like screening of antenatal women for hemoglobinopathies, newborn screening for hemoglobinopathies, and common metabolic disorders like congenital hypothyroidism, congenital adrenal hyperplasia, galactosemia, biotinidase deficiency, hemoglobinopathy screening. So the Department of Biotechnology under the Government of India has come up with the Ummeed initiative, which is a 3-pronged approach in which first is the training of in-service clinicians. So the 8 centers of excellence which were identified in the first phase were offering 6 months fellowships to with clinicians across the country. Until now, I think 50 or more than 50 people have been trained under this training of in-service clinicians initiative under the Ummeed, which is the unique methods of management of inherited disorders initiative taken up by the DBT. The second component of this Ummeed was the establishment of these Nidan Kendras to increase the diagnostic facilities across the country for early detection of these genetic disorders. And the third component under the Ummeed program was adoption of aspirational districts. So each Nidan Kendra, if it adopts, so across the country, there are more than 25 districts which have been identified based on their poor maternal child health indicators. So if each Nidan Kendra takes up one district and uh, covers the district for screening for antenatal women and newborn screening for common metabolic disorders and hemoglobinopathies, early identification and early intervention will probably help in improving the health indicators of these aspirational districts. So in the first phase, 5 Nidan Kendras were allocated, but in the second phase now, a total of 33 Nidan Kendras have been allocated, which might in the third phase increase to up to a number of 50 to 55. So this is the three-pronged approach under the National Rare Disease Policy, under the UMEED initiative of DBT. So these are some of the initiatives which have been taken up under the National Rare Disease Policy, which still is in a phase of evolution, with inputs being taken from all stakeholders to improve the provision of comprehensive healthcare facilities to individuals suffering from rare disorders, which we have seen that though individually may be rare, but collectively pose a significant health burden on the community. So I think I'll stop here and over to you, Dr. Ravindra.
Thank you so much, ma'am, for your presentation, despite of your busy schedule in this Center of Excellence meeting. I have one question that you said there is a database or the government or Ministry of Health and Family. Is there any database of the centers available for prenatal diagnosis and these NBS and UMIC program, where the actually peripheral doctors can the samples are referred to the patient who require the prenatal diagnosis services or
Dr. Ravindra, can you please repeat your question? I lost you in between. You are asking for a database on?
Database on centers where prenatal diagnostic services are available for genetic disorders. And
so, as I mentioned, that 5 Nidan Kendras were allocated in the first phase at AIMS Jodhpur, Lady Harding, Calcutta, and there were 2 more. So these 5 Nidan Kendras and the centers of excellence, 8 which were there initially in the first phase, that list is available online under the NRDP document itself and on the National Rare Disease portal also. So there all these have availability of prenatal diagnostic facilities. I'll share the list with you if you want. And the next set of Nidan Kendras, the list has recently been released. Sanction letters being sent out to all 28 more centers who have or are in the process of establishing prenatal diagnostic facilities. So that list is also available in the public domain. I can share that list with you for dissemination also.
thank you so much, ma'am.
Okay.
Now I invite Dr. Nirja.
Thank you, and I'll take your leave.
Thank you, ma'am. And Dr. Ashwin is busy in some parliamentary meetings. Now I invite Dr. Nirja to discuss about the mission program on pediatric rare genetic disorders. Over to you, Dr.
Yeah, thank you, Dr. Ravindra. So I'll just share my slides. Just give me a minute. Can you see my screen?
Not yet.
Not yet. Just a moment. issue, I think, here. Just a minute. So, Dr. Ravindra, can I send my slides to you? Is it okay to open it from there? Because I have some technical issue. Hello?
Yes, you can email me.
Okay.
Meanwhile, slides are coming. Can I ask Dr. Kaushik a question that has been asked by the audience in a chat box? Dr. Kaushik?
Yes, tell me.
Yes. So there are 2-3 questions that are coming on the chat box from the audience. That prevention and possible solution to the rare genetic disorder without gene therapy. So how we
Without
can.
gene therapy. Yes, 1 minute, let me. So there are so many without gene therapy because whatever I have discussed are not real gene therapies. Like when the enzyme is deficient, we can give enzyme replacement therapy. We have various oligonucleotides, various RNA-based therapies, and they are really marketed drugs, and we can use them. They are FDA approved. Some of us are, and also I have mentioned about dopamine, which can be given. There is biotinidase deficiency. We can give biotin. Dr. Anupriya had discussed biotinidase deficiency. It's a disorder where there is intractable seizure, and once we give biotin, it is so much treatable. So gene therapy is not the treatment for all genetic disorders. That is slightly remote. It is though available for many like SMA and some other hematological disorders as well. But yes, there are other ways too. So what are the other questions? I can't see the chat box.
What are the easiest and economic method for the diagnosis of rare genetic disease?
Oh, again, it is probably the best way is to consult a person who are an expert of that disorders. Like for most pediatric disorders, either a pediatrician who is trained in genetic disorders for all fetal anomalies, maybe an obstetrician who is trained in fetal genetics disorders. We rarely get medical geneticists all over the country, but yes, there are people who are trained in clinical genetics, and according to the disorder we choose the test. Like I told that when we suspect a chromosomal disorder, we do a karyotyping or microarray MLPA fish as per the need. When we think it's a single gene disorder, it's a small gene, we go for Sanger, or if it is targeted like for thalassemia, we do Sanger, we never do a NGS. For those genes which are very large or there are multiple genes, we do NGS. But first of all, like in my talk, I have told that first we have to suspect. When your mind does not know, eyes cannot see. So all genetic disorders may not be diagnosed by one person. So we require experts for each genetic disorders. And the primary physician should know where to refer, whom to ask. And there are various ways to contact now: emails, WhatsApp, so we can see pictures. We have telemeeting with people all over the country to diagnose. So it's the approach is not one. There is no single test, maybe which somebody can tell and somebody can advise and get a disorder. Are there any more?
Thank you so much, sir.
So,
Now
Yeah,
I
Dr.
have
Ravindra, can you see the slides?
slides are visible.
Are they visible? Are they moving?
Yes.
Okay, can I start?
Yes.
Okay, so good evening, everybody, and I'm extremely sorry for the technical delay because of this online screening. So I am Dr. Neeraja, and I'm a project scientist in mission program in pediatric rare genetic disorders. And this is a project which CDFD, Center for DNA Fingerprinting and Diagnostics, Hyderabad is the nodal center. And the project is funded by Department of Biotechnology, Government of India. And this is a pan-India initiative constituting 16 centers across the country. And to begin with, I don't think I have to give any more introduction after the eminent speakers have talked about and given quite a broad introduction about rare diseases, how rare are they, and how chronically debilitating situations they can lead to, and the percentage of affected children or patients across the country and across the globe are already mentioned. So I would not go into the details of it, but I would rather tell you that the goal of the project is to reduce the burden of the rare diseases in India by the joint efforts of doctors, scientists, and citizens across the country. So to begin with, I want to tell you that these are the 16 centers which are part of the mission project funded by DBT. And as you see that they are widespread across the map, and starting from Jammu Kashmir till Madras and Kerala, we have 16 centers who are actively contributing for this particular project. So I would like to shed light on the objectives on this of this project, and which includes primarily the recruitment of patients, followed by screening the genome and exome of those patients using latest exome sequencing and genome sequencing. And further, we also deal with the counseling of the patients and the families with the variants that are identified during the course. And the second larger objective of this particular project is to functionally evaluate the variants which are identified in the exome sequencing using different model organisms. So CDFD and ILS Bhubaneswar is scientists from these two centers are contributing to the functional characterization of the novel variants which are identified in our the entire duration of the project. And we also have scientists who are doing the in silico prediction of the variants which are being identified. And apart from that, we also have a team from CMC Vellore who are actively working on the gene editing of the hematopoietic cell lines, and also using lentiviral gene therapy or using CRISPR-Cas9 based gene editing. And we are also actively involved in creating awareness programs so that we spread the word of how debilitating rare genetic disorders can be, and what are the efforts which NPRD policy has made, and individual centers are extending it to common people. And we also want every clinician who are part of such kind of genetic counseling and genetic screening to be part of the project as well. So to begin with, I also would like to highlight that we have started with the development of a database. The idea is to create a database of the variants we are representing the Indian population. And I also request all of you to go through our website, which is Project website, wherein we are collectively working, all the 16 centers are working collectively to recruit the samples, recruit the patients, send the samples, sequence the samples, and create a whole big database of the variants. And in that process, we have a very stringent process of recruiting the patients, wherein we have framed certain specific SOPs for recruiting the patients, wherein we include the patients based upon the existing medical reports, clinical examinations, and the biochemical methods or tests with which it has been ruled out that the patient is suffering from rare genetic disorder. And we also have framed some exclusion criteria, which is if a phenotype is not extensively recorded, or if there are any incomplete supportive investigation is available, and if there is any preformed genetic tests are not done properly, and any acquired disorders like birth asphyxia, polymyositis, dermatomyositis, etc., such patients are excluded from our study. Sorry. So to begin with, I also want to give you a statistics that how the samples are, the patients are recruited across these 16 centers, and the exome analysis is being carried out at CDFD, and this statistics goes on increasing with the upcoming time. And center-wise numbers you can see, wherein the cases, how many they are recruited from each center, followed by the sequencing status, and followed by the exome analysis. And we also take some samples for genome sequencing, wherein we do not find any variant identification in exome. We also try to do the genome sequencing. So a collective effort from all the 16 centers is currently in progress. So as I said, that the variants which are identified during the exome sequencing are being taken up by the functional scientists who are actually characterizing using different model organisms. So to give you a glimpse of it, I wanted to show you this slide, wherein, I'm extremely sorry, wherein a variant was identified, homozygous variant was identified, which is leading to a neurodevelopmental disorder with microcephaly, seizures, and spasticity. And this particular variant was to be characterized, and a team in CDFD has taken up this particular case, and using Drosophila as a model organism, they have tried to characterize the gene. And towards that, we attempted to, the team in CDFD, Dr. Rohit, has attempted to delete partially the AIMP2 gene in Drosophila, and they have characterized the flies. So it is observed that the partial deletion of such gene has led to the movement and the locomotion related behavioral aspects. There was a defect in the flight of the Drosophila was observed. So such kind of different scientists are actually involved using different model organisms, and due to the time constraint, I will not be able to present all, but this is an extended version of the work which is carried out at CDFD by different functional groups. Further, we also are contributing towards the addition of collection of the data, because it, as you can see, that it includes very stringent and extensive widespread exome sequencing. So what we do is the samples which are collected across the country are being subjected to sequencing, and this data is again submitted to IBTC, which is the Indian Biological Data Center, wherein the data is being taken as a repository for as a representative of the Indian population. Apart from that, using an Amazon web-based cloud services, we transfer the data to multiple centers who are the collaborating centers of included in this particular project. And the key objective in our proposed project, ongoing project, is the awareness. So multiple centers across the country are involved. The collaborating centers are at their end, they are participating in creating the awareness by means of conducting awareness programs. And you can see a glimpse of it on the slide, wherein you can see the pictures wherein multiple centers are involved in spreading the word to the clinicians, the school children, and to the hospitals. So each and every center has been actively working on it. And onto your right, you can see that the infographics which are designed during the framework of the project, wherein the clinicians are the flyers pertaining to draw the attention of clinicians is designed, and also for genetic disorders awareness, the infographics were designed, and these infographics are widely distributed in conferences and in also in all the OPDs and in all the awareness programs. So the idea here is to mainly to spread awareness to multiple through the mediated through the multiple centers to each and every clinician, so as that so that they can actively engage themselves in joining their hands to this particular project. Apart from that, I also request all of you, the listeners, that you can follow the updates of Mission Project on Instagram, Twitter, and also in LinkedIn. And also we have a project website wherein the updates are continuously updated. We do arrange workshops for exome sequencing, analysis, and other molecular techniques, and also based on NGS. And I request all the students who are the listeners to participate actively in these programs. And also I'd like to request all the clinicians who are part of it. So even if you are not the collaborating centers, we also request that if you have any such interesting cases which you would like to extend for not only for exome sequencing, but also for the variant characterization using functional methods, we also would like to request you to be to approach us and to join our group of adding more data. So lastly, I thank the PI of the mission program, Dr. Ashwin Dalal, for the active participation and also giving the opportunity to me to present our updates to you. And definitely the PIs, co-PIs, and the staff of the mission program of all the 16 centers who have been actively working in successfully executing the project, and definitely DBT for funding the project, and clinicians across the country who are not even part of the project, but still they have actively come up in contributing and submitting the cases to us, and patients and families also for their continuous support. And lastly, I thank you for all of your attention, and I would like to end this slide. And this is an art which is created by one of our genetic counselor in the project. And I dedicate this art of hers for the Rare Disease Day of today. Thank you so much for your attention.
Thank you, Dr. Nija, for giving the project update on patient program on pediatric genetic disorders. Now I invite Dr. Kuldeep Singh, sir, which is a Dean of Academics and Professor in Pediatrics in Jodhpur. And he served as the Head of Department of Medical Education Technology and Nodal Officer for Center of Excellence in Rare Diseases by the Ministry of Health and Family Welfare. Despite of his busy schedule and meetings today at Udaipur, he is able to take some time for this rare genetic disorder. I thank you so much, sir. And now I invite Dr. Kuldeep Singh, sir, for enlightening us on genetics in public health.
Thank you, Dr. Ravindra, for inviting me and for this opportunity to speak on behalf of AIMS Jodhpur. Today is the World Rare Disease Day, and we are having a nation symposium on rare disease Udaipur. So I'm just late, and I think everybody is also maybe feeling tired during this time. So I will quickly go through this topic, is genetics in public health, which is based on the our real story, which is a very innovative story. So so is my PowerPoint visible?
Yes, sir.
Okay. So the public genetics in public health. So this is AIMS Jodhpur, which is located in the center of Rajasthan, and Rajasthan is the largest state in the country, with a variety of language as well as variety of landmarks. Like there is a hills also, there is plains also, and there are desert also. So the objective of my talk is to, through this center in the public health, to acquire the active data about some of the rare disease which are existing, along with some other public health issues. And the second objective is facilitating and reinforcing the high value acceptable clinical services for travel, which are not amenable to treatment by the local practitioners or healers. Third is a health awareness activity, including that for the genetic disorders and also mobile outreach clinic. And fourth is training and capacity building for traditional for and the local practitioner for the development of modules for prevalent, common, and rare disease. And lastly, to validate the innovative interventions for the cost-effective healthcare delivery. So this model is based on a Sirohi. In a Sirohi, there is a place which is known as Abu Road, which is 240 kilometers from AIIMS Jodhpur. And from city Sirohi, it is 60 kilometers. And it is at the base of the Mount Abu. So this is a center which has been given to us for 5 years research for piloting how the tribal health can be improved through innovations. So this was the MOU which was signed by the state government, and this center had come up now. So objective first was to acquire the data, active data about the common conditions, for which we use the travel-centric research. And in this, we use the innovative health intervention among the tribal women for improvement of the maternal and early infant health, and also mapping of the traditional healers and their practices, and screening for hemoglobinopathy and genetic disorders. So this was awareness activities carried out initially, and during this awareness activity, we also surveyed the population for the common prevalent conditions. And there was a health awareness was also an opportunity to gather into the what is their expectation, because the tribal people don't really mix with the other people. So we started with the support of the NHMA screening and preventive program uh, funded by the National Health Mission in Rajasthan. And we provided the comprehensive care. That is if the screening is done for all the age groups, from the newborn to the pregnant woman to the adolescent boys and girls, uh, and the school college going students. In the antenatal, if they are having some issues or some abnormalities detected, they can be counseled and referred to AIIMS Jodhpur for the prenatal diagnosis. There was a challenges for the screening program because some of these are in a very remote area where there is no roads, and we have to reach like this. So in the upper left corner, we can see that we are collecting the samples in under the rock. So we collected almost 10,000 samples, and out of this, pregnant women were 190, and we found some of the compound heterozygous patient. They were referred for the antenatal diagnosis. And the college students were screened, but again, they were found to be heterozygous. So another program was that for adolescent girls and boys, there is a acclaimed model residential schools, which we targeted for creating awareness, because we thought that creating awareness among these population, we can reach to the parents also. So this provided a very huge opportunity. So based on this, we framed the second objective is reinforcing and facilitating the high value acceptable clinical services for the tribal people. And for this, we use the telemedicine. Now, this telemedicine module is also very innovative in Sirohi, because here, in the presence of a health worker, the counseling and the treatment is given to the patient. And then through the telemedicine, we introduce a program which is known as NITHR for using the telemedicine in the remote area. And based on that, we were able to diagnose some of the rare conditions. Like one patient who was undiagnosed with a sickle cell disease was diagnosed because he was having some other manifestation. So our residents and the doctors were able to pick it up. Similarly, a woman came with a abnormal menstrual history, and that was found to be having Rokitansky syndrome, and this was counseled by the gynae, obstetrics and gynae department. So, telemedicine was one of the area which improves the public health access to the genetic uh, services. Third was health awareness activity and mobile outreach. Again, in this, we use what is known as field telemedicine. That is, an internet connection was established at a center, in a peripheral center, where the counseling was provided with the help of medical officer. Also, we conducted every Saturday some camps in the area, which are in a very remote area. Then we also targeted about the training and capacity building for the local healer practices. So the people in the tribal area have more faith in the traditional healers, local healers than the doctors. And we prepare a module. We conducted training module for the people. Out of 1,000, there are 200 traditional healers. They were willing and they were using some type of practice, which was healing in nature. So we targeted these group and we prepare a module for some of the common 10 conditions. They were trained about that. So this include common anemia and how we can find out whether this anemia can be a sickle cell disease or hemoglobinopathy. So this module was again given to the traditional healers. And based on that, we also found that developing an app which is useful for the traditional healers as well as the ASHAs and the ANMs which are working in that. This app was known as MY, that is Maternal Child Health Application through Intervention. So this is Android based and it was found to be useful to give some awareness about some of the common conditions. So lastly, our objective was to validate the innovative healthcare interventions and in which we use the health technology assessment also to validate whether the service we are providing are affordable and cost effective or not. So we also venture on a special program which is known as ROR, that is rotation of a resident. So a clinical medical residents from the AIIMS Jodhpur, they were deputed there for 6 days. This was started in September 2023, but in the last 4 months, there is a marked improvement in the way they are handling the situation in the tribal area. So they every day they are connected to the faculty from AIIMS Jodhpur in the morning class, and their guest lectures or seminars or some journal clubs are presented. And in the morning time, they go to the OPDs of the CSC and also visit the peripheral centers. So another initiative we have taken is the drone. So this was suggested by the Ministry of Health and Family Welfare that the drone, every AIM should adopt a drone activity, and we have chosen Abu Road. In the Abu Road also tribal dominated area is Pindwara. So this drone will collect the samples from that place. It will come to the Sirohi center where the analysis could be done. And those who are having positive, and if there is an antenatal case, the husband will also be tested. And if they are also positive, then they will consult through a teleconsultation. And if they agree, they will come to AIIMS Jodhpur for prenatal diagnosis. So in this way, we are reaching to the masses through for the rare disease through the involvement of the public health department. So AIIMS Jodhpur is also one of the center which has a school of public health, and they have multiple programs like master's program and executive program, and shortly we have started the MD MPH dual degree program also. So these are some of our social media channel which can be subscribed and they can be accessed. And lastly, telemedicine does not require any very strong or very high technology. It can be done with a simple mobile phone also. As this in this, I am consulting the patient and observing the patient is having a distress or not from AIIMS Jodhpur in a remote area. So wherever there is a will, we can do it. And public health genetics is one of the component which can improve the healthcare for the rare disorders. So this is all I would like to say. Thank you.
Thank you so much, sir, for giving us a wonderful talk on new initiatives for taking the rare genetic disorder to the public health, because the limited facilities, the most of the patients are not able to diagnose and misdiagnosed. At the end of the session, it is my duty to say all thanks to all the speakers and comes. So firstly, I thanks to our director, sir, Prakash sir, for giving me this opportunity to conduct this webinar and providing the facilities for this successfully organizing. I thanks to all the speakers, Dr. Anupriya Kaur, Dr. Manisha Madhekar, Dr. Kaushik Mandal, Dr. Bhavna Dingra, Dr. Kuldeep Singh sir, Dr. Ashwin Dalal and Dr. Nirja also for giving us valuable lectures, and I am sure that the participants all benefited for this rare genetic disorder, and that we hope that many more sessions will be going on in future, so that we can spread awareness for the rare genetic disorders in the community and to the society. I thanks to all our IT team and our project staff also for organizing this event. So I thanks to all from my heart. Thank you so much to all.
Okay, thank you.
Thank you all.
Thank you, Ravinder. Bye.